Yeah. Okay. All right. All right. Well, I hope you can all hear me, and if it's possible, if you can mute your devices as we go, so there's not so much feedback. Well, good afternoon, everyone, and welcome to today's Paediatric Teaching. Before we start today, perhaps it's appropriate to note the passing of Dr. Naomi Pommet, one of our colleagues, and it's a very sad day actually for the paediatric family. But we have to go on, so we will. We've had this is the 30th session of paediatric teaching for the year, the 30th one, and I'm running out of topics to talk about, but I thought we hadn't talked about liver disease and jaundice in children, so I thought I'd do that today. And so that's what we're going to talk about today. So I'm going to say some as always, I'm going to try to say something about the pathophysiology and link that to clinical things that we see, because if we understand the basis of it, the anatomy and the physiology, then we'll understand what we're seeing in clinical cases that we see. So I'll say something about liver functional anatomy and physiology, so you understand what the liver actually does, all the things the liver does. And I'm going to say something about tests of liver function, because we sort of get used to thinking about tests of liver function as if they're all the same, but they're actually not. They tell us different things about what the liver's doing. And I'll say something about the signs of liver disease, and then we'll talk a bit more about neonatal jaundice, most of which is not liver disease. Most of jaundice in newborn babies is not because of some problem with the liver. It's mostly physiological. And then I'll say something about jaundice and liver disease in older children, which is about problems with the liver. It's not physiological. So this will be the way the talk goes, and we'll record the talk and I'll send it around in case you miss anything or your lines drop out or whatever. Well, first of all, it's really important thing to understand is all the different parts of the liver, and we sort of get to think of the liver as just being the liver, but actually there's lots of different components to the liver and they have different functions. And so there's the liver tissue itself, and the liver tissue is made up of a number of different types of cells. And the first one, which we sort of know about, are the hepatocytes, and they're the main liver cells, and they function in terms of taking up and storing glucose, the breakdown of glucose from glycogen, so that the blood sugar is maintained, and the liver cells themselves make lots of proteins, and they detoxify wastes from particularly from the gastrointestinal tract. So I'll talk more about the hepatocyte function a little bit later. Hold on, I'll just admit Angie to the talk. Then there's hepatocytes within the liver tissue. There's hepatocytes, and then there's cells called stellate cells, which make fibrous tissue. And so when you get when the liver's injured, sometimes the stellate cells produce lots of fibrous tissue, and that leads to liver fibrosis. So they're overactive, if you like. So there's hepatocytes, stellate cells, and then there's these things called Kupfner cells, which are like macrophages, but again, it tells you the liver has multiple different functions. And one important function is an immune function. And when you don't have good liver function, then you often have immunodeficiency, like it's a form of immunodeficiency, because the liver has a very important role in processing antigens, like foreign antigens, especially those that come from the portal vein. So when if we eat something or we ingest something, then that will be filtered off, often be filtered off by the liver, and it may involve the immune function cells, which are called Kupfner cells, which are in the liver. So think about the liver as being mostly hepatocytes, but also these stellate cells that might make fibrous tissue, but also cells that have an immune function. The second, I'll just let NRH in again. I think their internet is a bit unstable. So there's the liver parenchyma, and the next part of the liver is the bile ducts. And the bile ducts, of course, drain bile from the hepatocytes and they drain it back into the gastrointestinal tract. And then the third component of the liver is blood flow. And this is really important to understand that there's blood flow to the liver, and 70% of that blood flow to the liver comes in the portal vein. And that comes from like the intestines. And that carries nutrients to the liver and other things, toxins and other things to the liver, and they get detoxified, and they get and glucose gets stored as glycogen, and then it's broken down to glucose again when the body needs it. So that source of blood flow, the portal vein, is low in oxygen content. So the liver's got to have some source of supplying oxygen, just like all organs, and that mostly comes from the hepatic artery, which of course just comes off the aorta, doesn't it? Hepatic artery. And from the liver, going back to the venous system, comes the hepatic vein to the IVC. So if you're not familiar with the liver blood flow, it's important to be so, because a lot of the liver pathology occurs because of abnormalities of liver blood flow. I'll talk about that in a little while. So try to understand the functional anatomy of the liver and what each of the components do. Like I said, the liver has many functions, and when there's liver injury of any sort, liver disease or liver injury, some or all of these functions are impaired. And so, of course, the liver produces bile and excretes bile. And I'll explain where that comes from and what that means in a little while. As I said, the liver has a really important role in detoxifying toxins and the metabolism of drugs. So particularly toxins that come from the gastrointestinal tract, like things we might eat, get filtered in the liver, but also the metabolism of drugs that we might, excuse me. That's okay. Also the metabolism of drugs and other things, the liver has a big role in that. And it's useful for us to know, or at least when we put children on certain drugs, to consider whether or not those drugs are metabolized by the liver. We've talked about that before, about some drugs that increase metabolism of other drugs in the liver, and some drugs that decrease metabolism by other drugs in the liver. But just to know that the liver has a very important role in the detoxification of toxins and the metabolism of drugs. And then, like I said, the liver has a big role in processing of nutrients from the gastrointestinal tract. So storage of glucose as glycogen, the mobilization of glucose, so that's glycogenolysis, where the glycogen is broken down back to glucose and then gets circulated in the body. And then, of course, the storage of fats. The liver also has a role in the making of protein. So when the liver fails, one of the most important problems that occurs is coagulopathy, and that's because the liver has a big role in the constant making of clotting factors. And so if the liver fails, then over time, like days or weeks, the patient's albumin will go low. But within a very short space of time, within often hours or days, the clotting factors go low, and coagulation becomes abnormal, and patients bleed. And so the liver has a very important role in the constant production of clotting factors. As I mentioned, it has an important immune function, the liver, particularly in antigens and bacteria and other things that come from the gastrointestinal tract. And the liver also has an endocrine role and produces like these hormones, hormones called insulin-like growth factors. And we've talked about angiotensinogen, which converts angiotensin 1 to angiotensin 2, and that is involved. Don't worry too much about that, but that's like involved in sort of vasoconstriction within the body. But just know that the liver has an important role in endocrine function and in growth. And that's why children who have chronic liver disease often don't grow very well, because they're not producing these hormone-like growth factors. Okay, so just we might not have appreciated all the functions that the liver has, but it helps because when there's some disease in the liver, then some of these or all of these become abnormal. And they can do so at different rates. Like some become abnormal within a few hours or days of the liver failing, and then some become abnormal much later, like weeks or months later. Okay, there's a few more people come online now. So just to orientate people, we've been talking about the liver and its anatomy and its functions, and it has I'll send the slides around, but just to understand the large variety of different functions the liver has, and the different parts of the liver control different functions. Okay, just one obviously important function of the liver is bile production and excretion, and I've tried to describe this because it's a really important part. And you know that bile, of course, comes from red blood cells, and red blood cells have a half-life of about 120 days, and then after that the blood cells break down and they're turned over. Your bone marrow is making more red cells, and the old red cells have to go somewhere. So the red cells are broken down and they produce heme, which is like a protein, and it's a pigment and a protein, and that gets converted into bilirubin, which is, to begin with, it's just heme or bilirubin in the serum. So it's not conjugated, it's just unlinked with anything else. And then in the blood, so that's in the reticular endothelial system. So that occurs in the spleen, also in the liver and other organs. Red cells are broken down into heme pigment, and then that's converted to bilirubin. And then within the bloodstream, albumin quickly combines with bilirubin, and that leads to a bilirubin-albumin complex, which is called indirect bilirubin. That's still unconjugated. It circulates in the blood. Bilirubin mostly circulates in the blood with albumin, and that's called indirect bilirubin or unconjugated bilirubin. And then within the liver, the bilirubin is conjugated by an enzyme called uridine glucuronol transferase, and that conjugates bilirubin and then leads to the conjugated bilirubin or direct bilirubin being excreted in the bile. And that then often gets taken up by gut bacteria, or get broken down by gut bacteria and then converted into urobilinogen, most of which is excreted in the feces, and some of it's excreted in the urine. And then some of it also goes back from the gastrointestinal tract, gets absorbed back into the portal vein and then back into the liver. So there's this thing called the enterohepatic circulation that just keeps going around. So bile gets excreted into the bile ducts and then into the gastrointestinal tract, some of which is converted to urobilinogen, and then that some of that goes back to the liver, but most of it's just excreted in the stool. So that's how the liver functions to get rid of the waste product of old red blood cells. But when the liver becomes abnormal, then obviously bilirubin rises, and different sorts of bilirubin tell us different things about what part of the liver is abnormal. So when we think about liver function tests, there are markers of different components of the liver, and when we look at a set of liver function tests, we need to decide which one of those tests are abnormal and what does it tell us about the liver. So there are markers of hepatocyte dysfunction. All right, remember I said the hepatocytes, they make proteins, they store glucose, they store glucose as glycogen. They have a lot of different functions, the hepatocytes. And so there are some markers of hepatocyte dysfunction. There are some markers of bile duct dysfunction, or what we call cholestasis, usually obstruction to the bile ducts. There are some markers of synthetic dysfunction, which is also hepatocyte dysfunction, but usually sometimes the hepatocytes can be just a bit inflamed, and that's when you get a rise in ALT. And sometimes the hepatocytes can be so damaged that they're not actually making the proteins they need to make. So then you get low albumin levels and particularly coagulation abnormalities very early. So that's when the hepatocytes are so damaged that they're not making enough of the things they normally would. And then there are markers of impaired hepatic detoxification. So again, a marker of what the hepatocytes should do. They should be able to detoxify the blood. And when they don't, then things like ammonia and lactate build up. All right, we don't need to worry too much about that. But if you've got mild inflammation of the hepatocytes, usually just the ALT is elevated, sometimes the AST as well. But if you've got severe dysfunction of the liver, then the child will have a severe coagulopathy. They may have low albumin. They'll often have a high ammonia or a high lactate. So there, as the severity of liver injury gets worse, then the markers of different functions of the liver show up. Okay, so just in terms of hepatocyte dysfunction, like just a bit of inflammation of the liver, even if a patient gets mild abnormalities of the liver, a mild injury or disease of the liver, then often their transaminases rise quite quickly. And so the one to look for is the ALT. Often we look at the AST or the ALT, but the ALT is much more liver specific. And while it is found in other organs, it's not as widely distributed. The ALT is not as widely distributed as the AST. And the AST is also found in muscle or skeletal or cardiac muscle and in red blood cells. So the ALT will be high, particularly when you've got inflammation of the liver, and the AST will be high if you've got other disease or injury elsewhere. If you've got a severe sepsis or viral infection, then sometimes the AST will be elevated. But the ALT is a bit more liver specific, so it's just one to remember. Lots of different diseases that occur in the liver can lead to a rise in ALT, and particularly like drugs that might affect liver function, or toxins or infections or ischemia. If there's been some ischemic hit to the liver, then the ALT will be elevated. So just look out for that alanine aspartate transferase. That's the ALT, and that's the most specific marker of liver injury. It doesn't tell us what the liver injury is, but it tells us that there's liver injury. Sometimes if a patient's got very severe liver disease, such that their liver's not functioning hardly at all, then their ALT won't be elevated because the hepatocytes will have been so necrosed or so damaged that they're not actually producing ALT. So that can be a bit of a trap, that you might look at the liver function and see that the ALT is not very high, and you might think that's a good thing, but sometimes that's a bad thing if the patient's very, very sick. So, but generally speaking, you'll find in patients with hepatic inflammation or dysfunction or drug-induced liver injury, then the ALT will be very elevated. Okay, if there's obstruction to the bile ducts, that's a different thing to the hepatocytes being very inflamed or injured. And the main thing to remember is with obstruction to the bile ducts, then the alkaline phosphatase or the gamma GT will be elevated. And if you've got obstruction to the bile ducts, then you'll have a high conjugated bilirubin, because the liver cells are conjugating bilirubin. That uridyl transferase is working and it's conjugating bilirubin. So it's making this form of conjugated bilirubin, but it can't be excreted because there's obstruction to the bile duct. So the conjugated bilirubin will be high, the alkaline phosphatase will be high, the gamma GT will be high, and usually there's bile in the urine because there's more spillover of bile. It can't be excreted in the gastrointestinal tract, so it circulates in the blood. The patient becomes jaundiced, and then you find bile in the urine. Okay, I won't talk about that too much, but just remember that the different liver function tests tell us different things about what specifically is wrong with the liver. Then I said that the liver has, sometimes if the liver cells are injured, then the ALT will be high. But if the liver cells are very badly injured, then what you'll get is a low albumin level because the liver's not making protein. And so a patient will often be edematous because their albumin is low. And early on, their prothrombin time or their INR, whichever you measure, will be elevated. And usually if you've got a patient with severe liver failure, then their INR will be higher, their prothrombin time will be higher. So there's a difference between the child with liver inflammation or liver injury or some liver disease and liver failure. Liver failure is where you've got a high prothrombin time, a high INR, low albumin level. The patient's jaundiced. They often have a high ALT, and they may or may not have a high gamma GT or a high alkaline phosphatase, depending on what the type of liver injury is. I just try to explain these liver function tests so that you understand the difference, what the different things they can tell us about the type of liver injury that there is. And then the last marker of impaired detoxification, of impaired liver function, is if you've got a liver that's really functioning badly, then often the liver can't detoxify the toxins or the proteins that it should. And particularly the two that are particularly abnormal are the ammonia level, which we can't always measure, but like it's just important to sort of know that the ammonia is often very high when a patient's got liver failure, and so is the lactate. The lactate is often very high. And the reason why this is important is because when the ammonia is high, that's when patients become drowsy or unconscious, because that leads to hepatic encephalopathy. If you've got a high ammonia level above 100 or so, then patients are very drowsy. They often confused, often combative, and then they become unconscious. So when you've got severe liver failure, then that's what's happening to the patient. Okay, so just to I'll send this around, but just to be clear again, if you to distinguish between a hepatic problem, that is a problem of the hepatocytes, compared with a cholestatic problem, then you can look at the different liver function tests and see which ones are abnormal, and that can give you a clue to what the problem in the liver is. So if you've got a hepatic problem, then your bilirubin, your unconjugated bilirubin, will be high. Often your conjugated bilirubin will also be elevated. You'll have more urobilinogen in your urine, and your ALT particularly, and sometimes often your AST will be high. And it might be that the gamma GT and the alk phos are normal or elevated, but if you've got cholestatic liver disease, then those things will be very elevated, and there'll be high alkaline phosphatase and a high conjugated bilirubin, because remember, the conjugated bilirubin is what the liver cells make, and then often it can't be excreted because of obstruction to the bile ducts. Sometimes in children, and especially in young children, we get a combination of cholestatic and hepatic liver disease. It's just important to be able to look at the LFTs and say, I think this is more hepatic or it's more cholestatic, because it can give you a clue as to what the underlying problem is. Some are a bit more likely to be drugs, some are a bit more likely to be like gallstones or other things. Okay, so I said at the start, we try to discuss the anatomy and the physiology, and then the abnormal liver function tests, and then that helps us understand what the clinical signs of liver disease are. And most children with liver disease just have jaundice, and there's often not much more than that. And but as a child gets sicker with liver disease, then other problems develop. And so often with jaundice comes dark urine, sometimes pale stools, depending on what the abnormality is. I'll explain that in a minute. And steatorrhea, which is just fat in the stools, because the fat's not being broken down because the liver's not producing bile salts. And often that leads to pruritus or itchiness. The child is intensely itchy because of the buildup of bile salts in the bloodstream. Sometimes there's hepatomegaly, like the liver's big. It's not always big, but sometimes it's big. And you can get a bit of an idea about what the type of liver disease is by the type of just how inflamed, large, tender the liver is, whether it seems like a congested liver, whether it's firm or hard, irregular or regular and smooth surface. So I think the examination of the liver is very important. And when we examine the abdomen, we really should be trying to examine the liver and see if it's enlarged, if it's pulsatile, if it seems congested, if it's tender. So go through that process of trying to do that, because that can tell you a lot about what the type of liver disease is. You know, if a child's got a hepatoblastoma or secondary tumours, then it's usually pretty rock hard and irregular. If they've got a fibrotic liver, then it's hard and irregular as well. So there's lots of things you can tell by just examining the liver surface and measuring the size of the liver and thinking to yourself, is this smooth or firm or hard or regular or irregular or tender or pulsatile? Yeah. Sometimes there's also splenomegaly in liver disease, of course, either because the same process that's affecting the liver was also affecting the spleen, such as like hepatitis. Viral hepatitis can affect both the liver and the spleen. Epstein-Barr, like glandular fever, can give you a big liver, a big tender liver and a big tender spleen. And then sometimes the spleen is enlarged because of portal hypertension. If the liver's so sick that the blood flow into the liver from the portal vein is obstructed, then you'll get portal hypertension and a backflow of blood. And often that's why you get esophageal varices and splenomegaly. Right? I'll explain a bit more about that in a minute, but just to know that the spleen can be enlarged in liver disease either because the same process is affecting both the liver and the spleen, or it can be just a backflow of blood. And then, as I said, sometimes because if the liver's not functioning well, it's not detoxifying the nutrients and the wastes that come from our bowel that get absorbed into the portal vein. If the liver's not functioning in that regard, then ammonia levels build up and other toxins build up, and the child becomes encephalopathic, confused, sleepy, often combative, just not themselves. That's why adults, you see a liver flap. Usually in children you don't see that, but patients become very drowsy. Sometimes, as I said, the skin changes, either pruritus, like extreme itchiness, or chronic changes of chronic liver disease. I won't go into them, but you know, clubbing is a feature of chronic liver disease. And then sometimes there's the clinical features of portal hypertension, which are splenomegaly and often visible veins on the surface of the abdomen, and of course sometimes gastrointestinal hemorrhage like hematemesis. I'll explain about portal hypertension in a moment. Just so as you know, I think it's, like I said, 70% of the blood flow to the liver comes from the portal vein, and the blood flow from the portal vein comes, of course, from the gastrointestinal tract, draining all the nutrients. And usually the portal vein drains into the liver, and but if there's disease of this is the venous circulation of the liver, and what happens when there's abnormalities, right? And so when if the liver is very sick and there's obstruction and there's some increased resistance to blood flowing into the liver, either the liver's enlarged and inflamed, and that leads to increased resistance of blood flow into the liver, or if there's thrombosis or obstruction of the portal vein, then you'll get what's called portal hypertension. And that means that the blood pressure in the portal vein, which is usually very low, usually the blood flow just goes from our bowel to the liver without much pressure. But when the pressure inside the portal vein increases, then what happens is that a lot of new collateral vessels, collateral veins develop within the gastrointestinal tract, within the bowel, and within the stomach, and around the spleen, and sometimes in the kidneys. And what that means is that the blood flows backwards through those collateral veins, but the collateral veins, they're not normal, but they're distorted, dilated veins that occur particularly in the stomach and the esophagus, and that's why and they drain blood back into the inferior vena cava, so that the blood has got somewhere to go. But they're enlarged and friable, like not very strong veins, And when the pressure in the portal vein increases further, then you can get bleeding from the veins that are within the gastrointestinal tract, in the stomach and the esophagus. So that's what happens in portal hypertension. And you can get it from liver injury of any sort, like liver fibrosis or a tumor, any form of chronic liver disease, and any form where there's an obstruction to venous flow, either from the portal vein itself or from the hepatic vein that drains the liver out, drains blood out of the liver. Anything that builds up the pressure inside the liver and inside the portal vein leads to this back pressure of blood and dilatation and distortion of veins. So the children we see with chronic liver disease who have gastrointestinal bleeding, that's what's happening within their body. Okay, I'm going to talk now about something a bit less pathological and just try to explain just neonatal jaundice, because I think you need to separate out what's liver pathology and what's just normal newborn jaundice. And important to know, this is so common, so it's important for us to know that, you know, more than half of all newborn babies get jaundice, and most of it's physiological, and it's because of the breakdown of hemoglobin F, which that is fetal hemoglobin. You know, most babies are born, the predominant hemoglobin is fetal hemoglobin, and that gets broken down pretty early. It has a shorter half-life than hemoglobin A and like adult hemoglobin, and so that's very useful for newborn babies and babies during fetal life. But then it gets broken down, and that is converted to heme, and then to bilirubin, and then that gets conjugated by the liver, like we said, and excreted in the bile. So the physiological jaundice occurs after day one, because hemoglobin F doesn't get broken down on day one, but it's usually not beyond 2 weeks. And so physiological jaundice is after day one. It's not too early, it's not too high, and it's not beyond 2 weeks. They're the three things to remember about physiological jaundice: not too early, not too high, and not beyond 2 weeks. And then there's some other jaundice that's just normal jaundice, I would say. And the main one is what we call breast milk jaundice. And it's not a disease, it's not a problem really. And about a third of all babies who are exclusively breastfed will become jaundiced. And partly that it's a bit like physiological jaundice, but you probably know that breastfed babies they're not constipated, but they don't pass stools quite as often. It might be once every 4 days, or sometimes even up to once a week. And probably it's believed that that's because the bowel is just absorbing all the milk, all the good nutrients. And probably breast milk jaundice occurs partly because of the slow transit time of breast milk through the bowel, and that leads to a slowing down of the way bile is excreted, and more of it then gets just absorbed in the intrahepatic circulation. It's not a disease, it's just normal physiology, but it would be wrong to treat it as if it's a disease. It's certainly wrong to stop breastfeeding. These babies are fine and they can just continue breastfeeding. And sometimes it goes on for, you know, many weeks, even up to a few months of life, breast milk jaundice. But as long as the baby remains well and the bilirubin levels are not very high, then I usually just check the baby out once a week and see that they're, you know, not becoming more jaundiced. Like I said, when we think about neonatal jaundice, this is different to jaundice in older children, but we should think about it as either being physiological or pathological, and also whether it's mostly unconjugated or conjugated. And there is some overlap between these categories. I'll send this around, but there's some overlap. But often when you've got very early jaundice, like on the first day of life, in the first 24 hours of birth, then usually it's almost always it's due to hemolysis or due to an infection. So that's what we should think about: hemolysis or infection in the first day of life. When and the bilirubin that's high, it's all indirect bilirubin. There's unconjugated hyperbilirubinemia, and that occurs with ABO incompatibility or RH disease or infection with a bacterial infection in the first day of life, neonatal sepsis in the first day of life, or some intrauterine viral infection. And then sometimes you get very high. So when you, as I said, you should think, if it's too early or too high or too prolonged, then we should think it could be pathological. If it's too high, think about hemolysis or infection. Sometimes malaria, like congenital malaria, that can give you a high bilirubin level. And if it's prolonged, then it might just be normal. Like if it goes on beyond 2 weeks and it's indirect hyperbilirubinemia, then the most likely cause is just breast milk jaundice. But sometimes it can be due to some pathology like hypothyroidism. This is important to think about, or malaria, and there's some other conditions. I won't go into them, but hypothyroidism, remember those babies often have umbilical hernias. Usually they have umbilical hernias and prolonged unconjugated hyperbilirubinemia, and they're usually a bit more floppy than normal. That's the way they are, and sometimes they're hypoglycemic as well. So if you see that constellation, like I always examine these babies that have got breast milk jaundice, and if they've got an umbilical hernia, then I usually do their thyroid function test just to check that I'm not missing hypothyroidism. That's all. And then sometimes the bilirubin can be conjugated and prolonged. All right. And so when you think of conjugated hyperbilirubinemia, remember we said that's because of some obstruction to bile flow, like biliary atresia, or sometimes with newborn babies and babies in the neonates and young infants, it's because of some sort of hepatic inflammation, like neonatal hepatitis or something like that. So these are all the different causes of conjugated hyperbilirubinemia, and they could be a bacterial infection or malaria or viral hepatitis. And there's a few other things. I won't talk about them, but the Torches infections also give you a conjugated hyperbilirubinemia. I think it's good for us to have some sort of standard for when babies need phototherapy, and we can't always measure the bilirubin level. So I have these clinical indications, and so always when newborn babies are jaundiced on the first day of life, then I give phototherapy straight away. If babies are preterm, like they're less than 35 weeks with jaundice, then I always give phototherapy. If the baby's got jaundice on the palms of the hands and the soles of the feet at any age, then I think that's an indication that the bilirubin is too high and you should start phototherapy. And if the baby, a newborn baby, has like a cephalhematoma, maybe they had a vacuum extraction and they've got jaundice on day 1 or day 2, then probably they're going to have like a lot of blood, like a lot of bruising that's going to break down over the coming days. And typically I try to give them phototherapy, even if it's not for the whole day, and you nurse them with their mother, but still they can get some phototherapy and you monitor their level of jaundice. And then if they've got jaundice due to hemolysis, if it's ABO incompatibility or RH disease, then I usually start by giving them phototherapy, because you don't want the bilirubin level to go very high and lead to like a bilirubin encephalopathy. So they're clinical reasons why you start phototherapy. And then I think it's good to have a bit of an idea about what, I'll send this around, but as I said, we can't always measure the bilirubin level and we can't always do it regularly, but you can get an idea based on where the jaundice is as to how high the level of bilirubin is. And so there's been studies done that have looked at if a baby's got jaundice below the nipple line, like usually it starts on the face and then it progresses down. And if the baby's just got a jaundice on the face, then usually the bilirubin level is not that high. It may be below 200. But if it's the jaundice below the nipple line, then usually the bilirubin level is above 205. That's the studies have looked at that and seen, usually above 205. And if it's on the palms of the hands and the soles of the feet, then often it's much higher. So I always think about it, is it just the face? Is it the face and the eyes? Is it above the nipple line or is it below the nipple line? And is it involving the hands and the feet? And so when I'm thinking about the likely height of the height of bilirubin levels, I try to predict it by that clinical examination. And you know about these nomograms that you can, it depends on the hours or the days of life, and it depends on the bilirubin level. And so there are indications for phototherapy for preterm babies and indications for phototherapy for term babies, all right? And depending on the hours of life. So if a baby's 3 days of age and their bilirubin level is 350, then they should go under phototherapy. Now, 350 would usually be, they'll be jaundiced on the face, they'll be jaundiced below the nipple line, and they'll have jaundice of the palms of the hands and the soles of the feet usually. There are indications also in this nomogram for when to consider an exchange transfusion. That's much higher, of course, but so that's one way of deciding clinically and with a nomogram as to when to give phototherapy and when to refer babies, etc. The WHO has this, it's similar to that nomogram that I showed you, but it has these cutoffs on day 1, day 2, and day 3 or more of life, depending on whether you're a healthy term baby or a preterm baby, for phototherapy and for exchange transfusion. And that's if you can measure the bilirubin level easily. But if you can't remember the clinical features that I mentioned, is it the face and the eyes? Is it above the nipple line? Is it below the nipple line? Is it the hands and the feet and the whole body, right? So if it's, you can get a good idea from that. But this is in the pocketbook of hospital care for children, and you can look up the nomogram. I wanted to briefly touch on biliary atresia because it's a relatively common condition, and also, yeah, it's a relatively common condition, and we can make the diagnosis quite well. I think this condition of biliary atresia based on clinical grounds. And babies with biliary atresia is an obstruction of the bile ducts, and it's a congenital obstruction of the bile ducts. And usually these babies, they may be jaundiced in the first day, but usually the onset of jaundice is around about 2 to 3 weeks of age. And they often have a very deep jaundice. Like this baby had biliary atresia, and you can see, I hope you can see, the baby was very, very deeply jaundiced. And the clue is that there's no bile pigment in the stools. So the stools are very pale. There's just like they're white. There's no bile pigment in it because there's complete obstruction to the bile ducts. And that's different to other forms of liver disease in babies, where there's usually some bile pigment in the urine, and sometimes there's more than normal. And so the urine is very dark because there's lots of urobilinogen in the urine, because it can't be excreted from the bile ducts. It builds up in the blood and circulates and then gets excreted by the kidneys. There's a very high conjugated hyperbilirubinemia, and of course, because the liver bile ducts and the canaliculi are mostly affected, then the alkaline phosphatase is high and the gamma GT is high. And usually these babies often have a coagulopathy, not because their liver hepatocytes are failing, but because their liver should make vitamin K, and that vitamin K is not getting into the bloodstream, and there's not absorption. Normally, the liver allows their fat-soluble clotting factors, and they only get absorbed they only get absorbed by the gastrointestinal tract if you've got bile salts. And if there's no bile salts getting into the gastrointestinal tract, then factors 2, 7, 9, and 10 aren't high. So there's vitamin K deficient bleeding in biliary atresia usually. And often the AST and the ALT will be normal. But the main thing is deep jaundice in a baby of 2 to 3 weeks of age with very pale stools. That's biliary atresia until proven otherwise. There is there is a treatment for biliary atresia, and some of you will have seen this procedure done by some of the surgeons. I know Mackley Matthews done some Kasai procedures, and I won't explain it too much, but where you've got the bile ducts can't drain from the liver, a new drainage of bile is made using a piece of the small intestine, and it's called the Kasai procedure. Don't worry about it too much, but there is a surgical procedure that can be done in these babies with biliary atresia. It's sometimes successful, but actually often these babies end up with a lot of cholangitis and a lot of liver infections after they have this procedure, like in the year or two afterwards, and sometimes it doesn't work after a while. But anyway, that's the Kasai procedure, the Kasai surgical procedure. And usually this piece of the intestine is attached to that one, but the surgeon just cuts it there and cuts the bowel, and then attaches one end of the bowel to the liver because there's no bile ducts, and the other end of the bowel to here. So the bile gets drained out here instead of it being out the bile ducts, gets drained through the small intestine, and the food comes from the stomach, and that just goes into the small intestine, so the food can meet with the bile salts, and there can be normality. But that's the Kasai procedure. Don't worry about that too much. I won't talk about galactosemia because it's relatively rare, except to say that there are some inborn errors of metabolism that can cause liver dysfunction. And so if we see babies that are jaundiced in the first few days of life and they seem very sick, then sometimes it's because of metabolic disease or inborn errors of metabolism. And one of those conditions is called galactosemia, and that comes from an inability of the liver to metabolize galactose, which is a component of lactose, glucose and galactose in breast milk. And this is rare, but it causes babies to be very sick with severe jaundice. And often these babies have severe septicemia. So I won't talk too much about that. This is a baby who actually had galactosemia, and you can see the baby was severely jaundiced and very lethargic, and had E. coli septicemia. So it's uncommon, but it does occur, and it does occur in PNG. There are other causes of inborn errors of metabolism that cause jaundice, and one common one that you know about is called G6PD deficiency. It's not a problem specifically of the liver, it's a problem of the red blood cells, but it causes hemolysis, of course, and that can, when we see a child who's got jaundice, we need to think, is the child got hemolysis, or is it a hepatitic problem, or is it a cholestatic problem? And I explained how you interpret liver function tests. I won't go through G6PD deficiency anymore, but there are many things that cause hemolysis in G6PD deficiency, including drugs, and some of the drugs we use, the sulfonamides, cotrimoxazole and primaquine, and aspirin, and non-steroidal anti-inflammatory drugs and viral infections. They can all trigger G6PD deficiency and trigger hemolysis. And we should, when we see a jaundiced patient, we should think, is it hepatitis? Is it cholestasis? Is it hemolysis? That's the way we should think. I wanted to briefly touch on older children. So we've talked about newborn babies and neonatal jaundice, but there are some common causes of jaundice in older children. And I suppose the most common one is just hepatitis A, viral hepatitis. And that's endemic in many countries. It's just fecal oral spread, just like it's an enterovirus. So enteroviruses circulate a lot, and hepatitis A is fecal oral spread like all the enteroviruses, and it infects most of us have had a mild case of hepatitis A by the time we're 10 years of age, and most of us didn't get any symptoms from it, but some children do. And usually if a child gets symptoms, it's usually 2 to 6 weeks after they have been exposed to hepatitis A, and it's usually with vomiting and some diarrhea, and then they get jaundice and a big tender liver. And sometimes they get sick, but usually they don't get very sick. So, but if you see a child who's got some particularly vomiting, abdominal pain, and sometimes diarrhea and an enlarged tender liver, and they're moderately unwell, then I guess they're most likely to have hepatitis A. But we need to make a distinction between, is it hepatitic, is it cholestatic, is it hemolytic? All right, and those children that have got hepatitis A, they've got a hepatitic picture. They've got a high ALT, they've got a high unconjugated bilirubin. Usually their gamma GT and their alkaline phosphatase are not too high, but always look for other things like G6PD deficiency. And then whenever you get a child who's got jaundice, you need to just take a really good history of drug ingestion, because there's many drugs that can cause liver dysfunction. And so I always think if I've got a child with a hepatitic picture, it's either drugs or it's viral hepatitis. I mean, they're the most common causes. And so think about the different drugs. One big important drug is paracetamol, and it's really important because there is a treatment for it. If patients have taken, either inadvertently been given, or sometimes sadly deliberately taken an overdose of paracetamol, there is a treatment for it called N-acetylcysteine, and that can prevent the liver failure if patients have taken too much paracetamol. But as I said, many other drugs that we use commonly, the anti-TB drugs and some anti-epileptic drugs, can also cause jaundice. So if you've got a patient with epilepsy or a patient on TB treatment, then it's most likely the jaundice, if they're jaundiced, that's due to drugs. But also think about other things. Is it hepatitic? Is it cholestatic? Is it hemolytic? Okay, and then of course think about whether a patient's, if they're very unwell, have they got septicemia? Because just common septicemia with pneumococcus can sometimes cause jaundice and severe disease, and as malaria can. I generally treat these patients with antibiotics, amoxicillin, gentamicin, metronidazole, just because you want to make sure that if they have septicemia, you're treating that. I try to avoid, in patients with hepatitis or liver disease that I think might have a bacteremia, I try to avoid the use of ceftriaxone and avoid the use of cloxacillin and flucloxacillin, because they can make cholestasis worse if you've got a jaundiced patient. So it's better to use these more commonly available drugs than it is to use ceftriaxone and cloxacillin. And then finally, I guess we've talked about common liver diseases in older children, like viral hepatitis, drug-induced liver disease. And then sometimes, rarely, but really important to try to make the diagnosis, don't miss it, is amoebic liver disease. And this isn't very common, but like if you ever see it, it's possible for us to make the diagnosis. And typically these patients have a very big tender liver, and they have a pleural effusion, and they have a markedly increased white cell count. They have a high neutrophilia typically. And the differential diagnosis is that it might have a big abscess from a pyogenic liver abscess, or they might have a tuberculoma, but they might have a amoebic liver abscess. And so if you see a patient that's got those features, like a painful hepatomegaly with a high white cell count and a pleural effusion, or marked elevation of the hemidiaphragm, and you might be able to do a CT scan and see these what are clearly abscesses. This is the liver, and what are clearly abscesses. It might be bacterial, it might be amoebic, it might be tuberculous, but don't forget amoebic liver abscesses, because they respond well to drainage or by a surgeon, and metronidazole. So that's why in jaundice patients I give amoxicillin, gentamicin, and metronidazole just in case, and I try to do a liver ultrasound to just have a look and see if there's abscesses in the liver, or if you can do a CT scan and drain an effusion if it's there. All right. Well, that's all I wanted to say about liver disease. I thought for those who weren't at the start, this is the 30th Paediatric Teaching session, and we're running out of topics to talk about, but I thought we hadn't talked much about liver disease and jaundice, so I thought I would talk about that today. I'm going to stop there, and if there's any questions, then I'm happy to